The conditions of the anal canal, the pathological processes which are taking place in the anal canal are the commonest presentation when you're sitting in a surgical OPD. So from today onwards, we will start discussing about the different pathological conditions which are related to the anal canal. And we'll be talking about the hemorrhoids today in more detail. But to get into the detail of today's lecture, you should know what the normal anatomy of the anal canal is. So the first thing we're going to talk about today is about the normal anatomy of the anal canal. So we all know that basically, there is a connection of the large intestine with the anal canal, and the part which is connected with the anal canal is called as rectum. And whole of the anal canal is about 4 centimeter, and there is a proper demarcation between the upper half of the anal canal and the lower half of the anal canal, and it's because of the presence of the dentate line. But before that, the upper half of the anal canal is connected above with the rectum, so you can say it's a anorectal junction, and there are some important structures which are forming an anorectal ring, or you can say a kind of a demarcation between the rectum and the anal canal, and this is an anorectal ring. So there are important structures which are forming this anorectal ring, like the puborectalis muscle and the part of the internal sphincter and the part of the external sphincter. So if you could appreciate in this diagram that this is part of the rectum, and this rectum is all the way coming downward and it's forming the anal canal. And the upper half of the anal canal is connected with the rectum, and it's forming, or a kind of a demarcation between the anus and the rectum is the anorectal junction, and there is the anorectal ring. So we talk about the different important structures which are forming this ring are the important muscles, and the most important muscle is a puborectalis muscle. And puborectalis muscle, along with the internal anal sphincter, or you can say the internal anal sphincter, which is located high up in the anal canal, and the external anal sphincter, which is located downward, or you can say the deeper, because we know that the external anal sphincter has got a superficial part and a deep part, but the deep part of the external anal sphincter, the internal anal sphincter, and the puborectalis muscle, they actually form a sling, or you can say kind of a ring, which is called as the anorectal ring. And this is important not only anatomically but surgically. It's very much important when you're dealing with the anorectal anomalies, or you're dealing with the anorectal pathology, especially the hemorrhoids, or you're dealing with the anorectal cancers. So this is the upper half of the anal canal, and this is the lower half of the anal canal. Now, the demarcation between the upper and the lower half of the anal canal is a dentate line. And dentate line is important because the epithelium of the anal mucosa is different. Like the upper half has got the columnar epithelium, and the lower half has got the squamous epithelium. Moreover, the blood supply and the nerve supply and the lymphatic drainage is obviously, the venous drainage and the lymphatic drainage is different for the upper half of the anal canal and the lower half of the anal canal. So actually, what happens is, like, the upper half of the anal canal is supplied by the inferior mesenteric artery, and the branch which is supplying the upper half of the anal canal is the superior rectal artery and the middle rectal artery. So these are actually the branches of the inferior mesenteric artery. The lower half of the anal canal is actually being supplied by the branches of the internal iliac, and this is the inferior rectal artery. So the inferior rectal artery is actually supplying the lower half of the anal canal. So if we talk about the venous drainage of the upper and the lower half of the anal canal, they are entirely different, because the upper half of the anal canal is actually draining by the middle rectal veins and the superior rectal veins, and the middle and the superior, the middle actually drains into the internal iliac, but the superior rectal vein drains into the inferior mesenteric vein. And we know that it's coming, the inferior mesenteric vein is actually coming from the abdominal aorta. Then you have the lower half of the anal canal, and the lower half of the anal canal is basically supplied, or you can say the venous drainage, if we talk about the venous drainage. So the venous blood is draining into the inferior rectal vein, and the inferior rectal vein is a tributary of the internal iliac vein. So the upper half is all, related to the inferior mesenteric vein, and the internal iliac, and the lower half is related to the inferior rectal vein. Now, if we talk about the nerve supply, the upper half of the anal canal is basically supplied by the sacral plexus, right? So it's more sensitive to stretch. It's not sensitive to pain. And the lower half of the anal canal is sensitive to pain, and it's a kind of the superior hemorrhoidal plexus and the inferior hemorrhoidal plexus. So the superior hemorrhoidal plexus is, has got the autonomic supply, and it's sensitive to stretch only. It's not sensitive to pain. The lower half of the anal canal is, by the inferior hemorrhoidal plexus, and it is sensory in nature. So that is the reason the external hemorrhoids are painful, but the internal hemorrhoids are not painful. Now, all the the hemorrhoids which are above the dentate line, they are called as the internal hemorrhoids, and those hemorrhoids which are below the dentate line, they are called as the external hemorrhoid. Now, another important thing to know is there are some anal columns and there are anal cushions which are present above the dentate line, and these anal cushions are a kind of giving a protective a kind of a support and a protection to the upper half of the anal canal. Now, sometimes what happens is these anal cushions, these are the foldings of the mucosa and the submucosa, and they are actually present above the dentate line. And sometimes when there is a dilatation of these anal cushions, or they become dilated tortuous, then they give rise to the hemorrhoids, which are actually the blue tortuous strangulated kind of anal cushions, and the internal are painless and external are painful. So the internal are arising from the inferior rectal, the superior, the tributaries of the superior rectal and the middle rectal veins. And these superior rectal, and they're actually the tributaries of the inferior mesenteric vein. So, and the lower half of the anal canal is with the inferior rectal vein. So inferior rectal is the tributary of the systemic, and the above, there's a kind of protosystemic anastomosis, or you can say, because the protosystemic anastomosis is present all over the body, and the esophagus and the paraumbilical veins, which are present on the interior surface of the abdomen, and they're also present on in the anal canal, and the superior rectal is a tributary of the portal vein, and the inferior rectal is coming from the systemic. So there is a kind of a protosystemic anastomosis between these, but that's a kind of a different condition. Okay, that's not related to the hemorrhoids, because they're they're called as rectal and rectal varices, right? And they are because of the portal hypertension, and because when there's a portal hypertension, there is formation of the varices, or there's a dilatation because of the back pressure, and because of portal hypertension, the blood backflows to the systemic, and there is a dilatation, and that's a different condition, which is called as the anorectal varices. Now, hemorrhoids is a different condition because it's arising from the normal anal cushions, which are present above the dentate line, and they are kind of folds in the mucosa and the submucosa. Now, if they are rising above the dentate line, the concept is clear. They're called as the internal hemorrhoids, and they're painful because the epithelium is columnar epithelium above the dentate line, and the nerve supply is actually coming from the sacral plexus, which is autonomic, okay? And the dentate line, the part of the anal canal which is below the dentate line. So if we talk about the nerve supply, so it's actually the sensory in nature, and because of that, they are sensitive to pain. The upper hemorrhoids, or you can say the internal hemorrhoid, they're sensitive to stretch, and the lower hemorrhoids, they are sensitive to pain, and the upper are painless, and the lower are painful. So, important thing to know is you should know the length of the anal canal. You should know the normal anatomy, the anal cushions which are present at in two anterior and one posterior position in the just around the anorectal junction, and you should also know about the demarcation between the upper half of the anal canal and the lower half of the anal canal. Now, there's some kind of concepts which are related to the generation, or you can say kind of causative agents for the hemorrhoids. And there are multiple theories which are trying to explain, and one of them is a portal hypertension. So I tried already to explain this point to you, that actually the anorectal varices, or you can say the rectal varices, they are actually not the true hemorrhoids. Okay, so they are actually the dilatation of the anastomotic sites which are present between the portal and the systemic circulation, and it's because of the portal hypertension. Now, if we talk about the other important causes, there can be carcinoma of the rectum, because if there is any carcinoma which is present above the anal canal, it's trying to compress these anal cushions, and they're trying to obstruct the venous flow. So whenever there is obstruction of the venous flow, there would be stasis, and the vein would be dilated in the torsions, and it will be resulting in the hemorrhoids. Now, if you could appreciate, this is actually the part of the rectum which is being connected to the anal canal. And if there is a mass in the rectum, let's suppose they hardened carcinoma of the rectum, so it's actually pushing down below and trying to compress the anal cushions. And these anal cushions, because of the obstruction of the venous flow, they become dilated, and there is a tortuosity, and the result is basically the hemorrhoids. Now, there are some other important causes which need to be discussed when you are talking about the causes for the hemorrhoids. So there's some local causes, and some there are systemic or generalized causes, right? So the local causes, there can be anorectal deformity, there can be hypotonic anal sphincter, because usually when there is a kind of a hypertonic, or there's a kind of a normal anal sphincter, it would be trying to establish, a proper channel and a proper venous outflow obstruction. So the main concept behind the generation is a kind of a venous outflow obstruction. And there can be some pelvic causes, like the gravid uterus causing the pressure, and there can be uterine neoplasm again causing the pressure. There can be ovarian neoplasm causing the pressure, and the venous outflow obstruction. And there can be kind of a bladder carcinoma or carcinoma of the rectum, and there can be some neurological causes. That can be paraplegia, and there can be multiple sclerosis. So what's actually paraplegia, multiple sclerosis doing? It's actually, we know that the anal canal is being supplied by the sacral plexus. So if there is some kind of destruction to the sacral plexus, that can actually lead, the paraplegia can lead to the hemorrhoids, and there can be the multiple sclerosis as well. So the first classification was the internal and external hemorrhoids, depending upon their position and their level from the dentate line. Now, if we talk about the internal hemorrhoids, they are actually divided or subclassified into primary and secondary internal hemorrhoids. So actually, the primary internal hemorrhoids are present at the position at 3, 7, and 11 o'clock position, which is normally a position of the anal cushions, and they are produced as a chronic constipation, or all the conditions, obesity, pregnancy, or the gravid uterus, which is actually trying to increase the central abdominal pressure, and that can lead to the engorgement of the venous supply. Now, if we talk about this is the same anatomy, which the diagram I showed you before. The demarcation is here, the dentate line, and the primary internal hemorrhoids are present at the position of the normal anal cushions, right? So these are the positions for the normal anal cushions, which are usually the 3, 7, and 11 o'clock position. Any hemorrhoids other than these positions, they're called as a secondary internal hemorrhoids. So these are the dilated, bluish, tortuous veins which are produced because of the obstruction to the venous flow. Now, there are different kind of theories which are trying to explain the development of the primary internal hemorrhoids. Now, one of those theories is actually the portal hypertension. Why the portal hypertension? Because we know that at the anorectal junction, or you can say at the level of the dentate line, there's a rich anastomosis present between the tributaries of the portal circulation and the tributaries of the systemic circulation. So whenever there is a kind of a portal hypertension, there's a kind of a back pressure to the portal circulation, and all the way is transmitted to the systemic circulation. And because of that, the shunts, or you can say a kind of a portosystemic anastomosis, which is present wherever in the body, they can actually lead to the dilatation of these anorectal anastomosis, or you can say the portosystemic anastomosis. But this is a separate condition. As I have already explained before, that this is a different entity. Initially, it was thought that is the same thing. So the theory is actually trying to explain it, but this is no more followed. But you should know that one of the theory was being proposed to address the development of the primary internal hemorrhoids. So this is no more accepted, but there's a separate condition which is the anorectal varices, and it's because of the portal hypertension, and it's like the varicose veins. Now there are some kind of other vascular causes which can be some conditions which are related to the collagen or some kind of intrinsic properties of the vessels. Okay, there can be hyperplasia of the corpus cavernosum recti. There can be some kind of other infections. Now, it's also sounds a different, less acceptable theory, because God has created a major protective mechanism, right? And there are some kind of very, very strong protective mechanism present around the anal canal to get rid of the infection. So this is also at least likely, but there can be some kind of infections of the anal lining, because it's all the time, most of the time is in contact with the stool, and we know that the anaerobic bacteria in the gram-negative cover, this is the flora of the intestine, and sometimes they can come along the stool, and that can lead to if there's a damage to the lining of the anal canal, there's a chronic constipation, or there's a kind of a fissure, that can actually lead to the development of the infection. There can be diet and stool consistency. This is the most important concept to be grasped when you're talking and when you're discussing about the hemorrhoids, right? So the first and the foremost thing is a diet, because those population which are actually taking less water in their daily routine, or they're taking a kind of less fibrous diet, right? And they're taking more of a proteinaceous food, or they're kind of taking more of the fatty food. This actually trying to make a more bulky stool, right? Because there's a less water and there's a less dietary fiber added or being present in your food. So because of that, there's a bulky stool, and sometimes because of the deficiency of the water contents, this stool hardened down, and when you are trying to strain, there is a kind of obstruction to the venous flow by that stool, plus the straining also increases the pressure. So because of that, there is a kind of a pressure generated altogether on these anal cushions, and that results into the dilatation and the tortuosity of these, or kind of a development of the internal hemorrhoids. Now, the stool's consistency is important because the bowel habits varies from person to person, and even if we talk about the individual, the bowel habits varies within the individual, and sometimes it's diarrhea, sometimes it's constipation, but most of the time the constipation is the culprit behind that. And because that's the only reason, if we talk about when you're trying to target and when you are trying to treat your patient, you actually are more focused on the dietary management, and you're more focused more focused about the stool consistency and laxatives, and you also advise your patient to increase the water intake, or you advise your patient to have more fiber containing diet in your daily nutrition. And the other, another important cause that can be kind of a theory in the development of the primary internal hemorrhoids is the primary anal hypertonia, or there can be aging. Now, the aging, why the aging is very much important, because, the collagen is responsible for giving you a kind of elasticity. So whenever the collagen fibers are they are being, as a process of the aging, the collagen is being degraded, and there is the turnover of the collagen is more as compared to the formation of the new collagen. And because of that, the elasticity of the tissue is being lost. And because of that, there's a kind of more pressure and more resistance to bear the pressure, and because of that, there is a formation of the hemorrhoids. Now, what are the features how the patient is actually going to present to you? If the patient is complaining about a painless bleed, always think about the hemorrhoids, right? But if you are encountering a patient who is 50 years and he's also giving you the history of anorexia and weight loss, think about the colorectal cancer, because the painless bleeding, whenever clinical features of painless bleeding, you think about the hemorrhoids, you think about the rectum. Never try to ignore the rectum. But in case of the rectum, the patient will also complain about the tenesmus, which is the incomplete sense of evacuation. And always try to rule out these things in your history by asking your patient. So talking about the clinical features, if usually they're painless, but sometimes they become painful when they're strangulated, or when they're thrombosed, or they're external hemorrhoids. They can become painful. And sometimes usually if the patient is complaining about the stool in the blood, or the patient is complaining about the PR bleed with a pain, you will think about other conditions, like you think about the anal fissure. So the fissure would be painful, but the hemorrhoid wouldn't be painful, it would be painless. And you would think about other conditions, and you would be more precisely asking about the pattern of the bleeding. Now, if the bleed is actually mixed with a stool, and you will think about anal fissure. But if there is a kind of a separate bleeding after you're done with the defecation and you have passed the stool, whatever it was, and then at the end of the defecation, there would be, there would be stool when you're trying to wipe on the paper, or there would be stool in the toilet, and then you will think about the hemorrhoids. The other thing that the patient can give you a kind of a history, that there is something coming out of anus, and then something coming out of anus with a bleed that would be hemorrhoid only. So the patient can present to you with a PR bleed. The patient can be anemic, because if there's a lot of bleeding, which is occasionally present, when there's a lot of bleeding, then there would be anemia. There would be anal pain if the hemorrhoid is strangulated or thrombosed, or there can be kind of lump at the anal orifice. You can say a kind of something coming out of the anus. But there can be some kind of anal irritation because of there's a kind of reaction from the skin, and there can be the kind of because there's a chronic irritation, and there is a lot of problem with the mucosa and submucosa, and sometimes that can lead to the anal irritation, and the patient will complain about the constipation. So the constipation with a painless PR bleed and something coming out of the anus, these are the cardinal clinical features. Other than that, there can be anal pain, or there can be sometimes there can be anal pain when they're thrombosed, and there can be anal irritation, or there can be something coming out of the anus. Now, Degrees of the internal hemorrhoids are important. There are 4 important degrees of the hemorrhoids, especially the internal hemorrhoids. So the degrees are related to the primary internal hemorrhoids. So there are 4 degrees: first degree, second degree, third degree, and fourth degree. So the first degree hemorrhoids are those in which the patient is only coming you with a complaint of PR bleed. So if there is only PR bleed, that would be first degree hemorrhoid, and there would be no prolapse. If there is a PR bleed and it is associated with the prolapse or something coming out of anus, the patient will complain that there is something coming out of the anus whenever he's defecating, but it goes back spontaneously on its own, or it is kind of reducing back to its normal position on its own. So these are the second degree hemorrhoids. So in the first degree, there's only PR bleed, there is no prolapse. In the second degree, there's PR bleed and there's a prolapse, or you can say there's something coming out of the anus, but it spontaneously goes back. Then there's a third degree hemorrhoid in which there's a PR bleed, something coming out of the anus, and the patient will tell you that it doesn't go back spontaneously on its own, and it has to be reduced manually by himself. Okay, these are the third degree hemorrhoids, and then there are 4th-degree hemorrhoids, which are called as a prolapse hemorrhoids, and they do not go back. They do not, either you try to do it manually, or they do not go back spontaneously. They remain externally. They are called as the prolapse hemorrhoids. So always remember there are 4 different degrees, and you need to identify, and you need to inquire your patient is suffering from which degree, because the treatment strategies depends upon the degree. So the 1st-degree hemorrhoid, there would be only PR bleed, no something coming out of anus. In the 2nd-degree hemorrhoids, there would be PR bleed and there would be something coming out of anus, but it goes back spontaneously when the defecation ends. Then there's a 3rd-degree hemorrhoids in which there's a PR bleed, there's something coming out of anus, and it does not go back spontaneously on its own, and the patient has to push it manually. And the 4th-degree hemorrhoids, in which there's a PR bleed and there's a prolapse hemorrhoid, and it doesn't go back on its own, but anyway, either spontaneously or manually. Now, it's important, very, very much important to classify these, because the treatment strategies depending upon these. So these are actually you can say these are kind of the swollen anal tags which are present externally, but this is the internal external hemorrhoid. So the internal external hemorrhoid is actually, that was the internal hemorrhoid, which now coming, the external hemorrhoids as a kind of a prolapse. So you can see the swollen anal mucosa, and you can see the irritation, and there's a redness and erythematous skin, all the anal on the anal verge. So these are the clinical presentations. Now there can be some complications to the internal hemorrhoid. There can be strangulation, there can be thrombosis, there can be ulcerations, there can be infections, or there can be gangrene, and the gangrene can be a kind of a wet gangrene or a dry gangrene. And there can be portal pyema, and there can be extensive extensive infection of the anal verge. They can be fibrosis. Okay, so always remember the complications of the hemorrhoid. There can be strangulation, there can be thrombosis, ulceration, gangrene, portal pyema, and fibrosis. These are the complications which are related to the primary internal hemorrhoids. So you can see in this picture that this is actually the prolapse hemorrhoid, and you can see the strangulation. Okay, because whenever there's a prolapse, there's obstruction, and because of that there's strong strangulation. There can be, because of that, there can be gangrene. So these are the complications which can be related to that. Then the external hemorrhoids are usually below the dentate line, and they are some, you can say, swollen. Usually if they're present in the form of the anal tags, then they do not, like, you don't have to do anything. But when they're swollen, when they're infected, when they're thrombosed, then you have to do the band ligation, or you have to do the hemorrhoidectomy, right? So now, moving on to the second part of the lecture, is the important thing is the treatment, the conservative treatment, the surgical treatment, and let's less invasive and then invasive surgeries. Now, the important thing is if the patient is coming to you with a PR bleed, the constipation, and the patient is also giving you the history of something coming out of anus, and the patient is telling you that he has got the painless bleed, then you think about the hemorrhoids. And the important thing is like you have to do the digital rectal examination. So what actually you have to look in the digital rectal examination, you have to rule out if there is presence of the anal fissure, there's a perianal abscess or something like that. And then you have to do the digital rectal examination, and you would see this color of the stool, you would see if there's any blood present on your finger when you're doing digital rectal examination, or you will check the sphincter tone, and you will also check, you can feel the internal hemorrhoids. But to properly locate, you need to do the proctoscopy, and it's a kind of a very friendly instrument, which is the proctoscope. And you just what you have to do is you have to apply the local anesthetic, mostly lignocaine gel is being used, and you apply it to the skin, and you apply to the anal verge, and then you apply the gel on your finger and the proctoscope as well. And after you are done with locally anesthetizing the patient, you insert the proctoscope, and you try to look for the presence of the internal hemorrhoids, and you try to identify if there's anterior posterior, or you try to look for the position. 3-7 o'clock position. These are 3-7-11 o'clock position. These are the normal position of the internal hemorrhoids, or kind of anal cushions. Now, if the patient is only complaining you of PR bleed, and there are no hemorrhoids, right? But there are hemorrhoids, but they're very small, and they're not. The patient is only giving you kind of history of the PR bleed. Then a conservative management should be offered. You should offer your patient a good laxative to make the stool a little softer, so that it passes easily, and the straining and that can be minimized, and the kind of obstruction could be relieved. So give a kind of a laxative. Then you have to give, if a patient is complaining you about the bleeding, then you have to give the patient tablet Daflon 500 mg, and there's a regimen for that. You give the 4 tablets in the morning, 4 tablets in the evening for 3 days. Then you have to give 3 tablets in the morning, 3 tablets in the evening for 3 days. Then you have to give 2 tablets in the morning and 2 tablets in the evening for 3 days. And then you have to give 1 tablet in the morning and 1 tablet in the evening for the rest of the 1 month. So this is the regimen for giving a Daflon, which is actually, trying to kind of causing a contraction of the smooth muscles which are present in the veins, and they try to obstruct that, and they try to compromise their blood supply, and because of that there can be less of the bleeding. And then you have to give you have to order for the sitz baths, and you have to tell your patient that you need to clear, or you need to clean this area on regular basis. And then you have to tell him about the pyedine or saline, lukewarm saline sitz bath. And then you have to give your patient a high fibrous diet, some vegetables and some salads and some cucumbers. And you also tell them about the ispagold, and you also tell them about some kind of good laxatives as well. So this is actually the conservative treatment, and you try to follow your patient every fortnightly. And after 2 weeks, if the patient gets better, that's okay. But if the patient condition is, he's still complaining of the pain and still complaining of PR bleed, and then you will think about other strategies. There can be injection sclerotherapy, or there can be bending, okay, which is the bend ligation. So what you do in injection sclerotherapy, actually, there's a combination of a phenol and almond oil, and you make a 5%, and you take a 5 ml of the phenol and almond oil, and you try to inject it to the pedicle of the hemorrhoid, and you try to visualize it by proctoscope, and you try to inject that fibrosing or kind of a sclerosing agent into the pedicle of the and if the patient is complaining you of the pain during the procedure, then that means you're not in the right plane, and you can cause pelvic sepsis, or you can cause a rectovaginal fistula or something, But think about, like, if you are in the same plane or in a correct plane, and you try to inject a sclerosing agent into the pedicle of the dilated tortuous vein or a hemorrhoid, then there would be a kind of a bulge. So the bulge will and tell you that you are in the correct plane. And then what will happen, that there would be kind of a dusky discoloration, and then later on there would be thrombus. So what happens is this sclerosing agent actually fibros the hemorrhoid. The other thing is, the banding, which is a band ligation, and there's a rubber band ligation, right? So what you do is, in case of the internal external hemorrhoid, or in case of the internal hemorrhoids, what you do is you do a banding ligation. So that actually you take a gun, and a suction gun is being used, and a gun is attached to the suction, and you try to press the pistil, and the rubber band goes to the base of the pedicle of the hemorrhoid, and then it is because of the thrombosis, and later on it sheds off within the 10 days, and you need to explain these things to your patient. So if there's a first degree hemorrhoid, manage your patient conservatively. If there's a second degree hemorrhoid, go for injection sclerotherapy. If there's a third degree hemorrhoid, go for the banding. If there's a fourth degree hemorrhoid, go for the hemorrhoidectomy. So all these things, you should be very much clear about the degrees. That's why it is important, very, very much important, when you are investigating or you're trying to make up a diagnosis. So there are two kind of syringes which can be used. One is the Gabriel syringe, and one is a disposable syringe, and these can actually be used. There's another other syringe which can be used, the spinal needle, 18 or 20 gauge needle, that can be used for that, and you need to attach us with the disposable syringe, and then you have to make a 5 ml of the phenol and almond oil, and then you need to inject it into the base, or you can say pedicle of the hemorrhoid, and you need to inject it in submucosa, and this is a 5% of the phenol. So if you could see if there's a kind of you're examining, and you're doing a proctoscopy, and there's a bulge right here, then what you do is get the submucosal 5% phenol and just inject it to the pedicle. And if sometimes, and you need to inject it into each individual hemorrhoid. If there are 2 present, inject it twice, or if there's a 3 of the hemorrhoid present, inject it thrice. And then you need to tell your patient, sometimes they respond efficiently in one section, but sometimes you have to repeat it, and you have to give the patient some antibiotic as well, because they're like flagyl or metronidazole cover is sometimes important. The other thing is the banding, which is the rubber band ligation, and you can see it's a kind of a gun, and you attach one part of the gun with the suction, and this is a kind of a nozzle, and you attach the rubber band on the nozzle, and then you try to shift that rubber band from nozzle to the gun, and then you try to do the suction, and you try to do the banding. Okay, so it's a kind of a, you can say that this is the hemorrhoid which is present, it's being banded, and after maybe a week or maybe 10 days, it's actually shed off, and there can be, you need to tell your patient that when there would be shedding of these hemorrhoids, there would be some kind of a slight bleeding. So it's expected, and you need not to be worried about that. Now there's some kind of operative treatment, and there are some kind of indications for that operative treatment. And the operative treatment is a hemorrhoidectomy, which can be open hemorrhoidectomy or closed hemorrhoidectomy. and which is the open hemorrhoidectomy, is a UK-based procedure. It is a Milligan-Morgan hemorrhoidectomy, and there's a closed technique as well, and there's a staple hemorrhoidectomy as well. And in case of those hemorrhoids, even second-degree hemorrhoids, which are resistant to the banding or sclerotherapy, you go for this. The third and fourth-degree hemorrhoids, you go for the hemorrhoidectomy. And you do the hemorrhoidectomy for fibroid hemorrhoids, or you do the hemorrhoidectomy for prolapse or internal external hemorrhoids, or maybe the external hemorrhoids which are swollen and thrombosed and causing you pain. So talking about the operative strategies, we talk about the open techniques and we talk about the closed techniques. So what you do is like in open technique, you leave the mucosa and submucosa open, and you do not actually stitch it, or you do not close the defect or the gap in the submucosa, right? You excise and ligate and transfix the whole of the hemorrhoid, and then you leave the submucosa like that, and you put an anal pack in, which is usually removed in the evening. This is the open technique, which is Milligan-Morgan technique, and it is being practiced in UK. The closed technique is a USA-based technique, and it's a kind of, when you ligate and you try to excise the whole of the hemorrhoid, then you close the submucosa with the Weichel suture. So make a lithotomy position or prone jackknife position and do the proctoscopy and visualize it and try to do the hemorrhoidectomy by open technique or by closed technique. So sometimes somehow very much easy. What you do is you try to grasp one corner with a forceps and the other corner with a forceps, and you try to in between the two of your forceps you make a triangle, okay? And then what you do is you hold this and you get to the base and you try to excise it from the base or the pedicle, and then what you do is you transfix and you ligate the rest. See, this was the hemorrhoid, which is now being ligated and transfixed at the base. And then if you close the submucosa, if you do not close the submucosa, it's the open technique. If you close the submucosa with the Weichel 30 or 20, this is the closed technique. So again, this is the post-surgical appearance of the anus, and you can see there are normal anal cushions present, and there are no kind of, in actually open technique, you also excise the mucosa and submucosa, right? But in the closed technique, there's a kind of preservation of the little bit of the preservation, but more is because in the stapled technique. So the closed technique is like, again, the principle would remain the same. You will do a proctoscopy and you will try to grasp the hemorrhoid by the help of the forceps, make a triangle, get into the base, and just try to remove it from the base and then transfix it, and then close this submucosal defect by the help of the Weichel. Again, there is another technique which is called as a staple hemorrhoidectomy. In a special staple, it's becoming more common in use with the passage of time and with the more techniques. So what you do is actually it's a kind of preservation of the normal anal cushions, right? So in conventional hemorrhoidectomy, either you're doing the open technique or you're doing a closed technique. What you do is you do not preserve the normal anal cushions, okay? So, but in staple hemorrhoidectomy, you try to preserve the normal anal cushions. And what you do is like you try to, this is a kind of a staple, and you just insert it and you go in, try to staple the base, and you try to preserve the normal anal cushion. So that's how it's a kind of a different strategy from that of the normal open conventional hemorrhoidectomy. Then there is another technique which is being used, but it's not very much common, and it's being used in advanced countries, and Haemorrhoidopexy. So it's actually, you're also strengthening the posterior wall. This is actually the simple procedure, and it's a kind of less invasive. Now, when you're done with the, if you do the injection sclerotherapy, or you do the, hemorrhoidectomy, staple hemorrhoidectomy, or open or closed technique, then important thing is like you have to provide your patient a good postoperative care, which is very much important. you need, if the anal pack is being introduced into the anal canal, then you have to tell your patient, and you need to take out this anal pack in the evening, because there is some kind of a bleeding after the procedure, and then you remove it in the evening. Then you have to tell your patient, or you have to give your patient some laxative, or some kind of a stool softeners, and you have to encourage your patient to take up plenty of fluids, or water, or clear water, or other things, and you need to increase the fibrous intake, and you need to give your patient, tell your patient about taking the pyridine or warm saline sit baths, and you need to give a good antibiotic cover. So 2 warm baths each day, bulk. Give a laxative twice a day, put the patient on good antibiotic cover. Sometimes if you combine augmentin with the flagyl, it's a kind of good combination. Then you have to tell your patient about the dry dressing daily, and good anal hygiene is very, very much important, like use of the normal sanitary towel. There's some postoperative complications you need to look for. There can be formation of the anal abscess, or there can be anal stricture, or there can be, fistula formation, and you need to look for these complications. So an important thing is, like, if you're done the procedure, whatever it is, this hemorrhoidectomy, or it's a Milligan-Morgan technique, or stapled, or you have done the hemorrhoidopexy, follow-up of the patient is very much important, and it's important if you follow up your patient after 3 to 4 weeks. So it's also important, if the stenosis occurred, then you have to do the anal dilatation, which is a kind of a very non-invasive procedure. Talking about the postoperative complication, there can be early complications and there can be late complications. So the early complication would be obviously the pain, okay? There can be acute retention of urine, and it's more common in the male as compared to the female. There can be reactionary hemorrhage, and there can be some late complications. And if we talk about the late complications, there can be secondary hemorrhage, there can be formation of the anal stricture, there can be anal fistula formation, there can be anal fissure formation, and the patient can actually present to you with incontinence when you're trying to mingle with the sphincters, because this place is very, very much important, because the internal anal sphincter and the external anal sphincters are lying, and when you try to cauterize them, or when you damage them accidentally, then the patient can complain about the incontinence. So the early complications are pain and acute urinary retention or reactionary hemorrhage, and the late complication would be secondary hemorrhage, anal stricture, anal fissure, or there can be incontinence. And you need to take care of these complications. Now, the external hemorrhoids are, again, below the dentate line, and they are usually, if they're just the anal attacks, then you don't have to do anything. But if they become swollen or thrombosed or prolapsed, then you have to go for the hemorrhoidectomy, and they are painful because they are sensitive to pain because of the sensory nerve supply. So the internal hemorrhoids have got the degrees, and the treatment strategies varies for the internal hemorrhoids. But for the external hemorrhoids, you are left with only 2 options. One is a banding, or you go for the hemorrhoidectomy. But most commonly, hemorrhoidectomy is being performed for these procedures or for these complications. So that's all for today's lecture, and we have so far discussed about the different conditions of the anal canal. We talk about a little bit about the anatomy of the anal canal, and we also talk about the hemorrhoids, the internal and external hemorrhoids, and we talk about their presentation, their degrees, and we also talk about the conservative treatment and the surgical treatment. We talk about the injection sclerotherapy, the banding, and the techniques for the hemorrhoidectomy. So that's all for today. Thank you for watching sqadia.com.